Good morning, everyone, and welcome to Medical Grand Rounds. Here we are for our first session of the fall of 2022. I'll go through just a few logistics first. We are here on the Teams live platform and continue to have Medical Grand Rounds as a joint effort between Providence St. Vincent and Providence Portland Medical Center. You can earn CME credit for being with us here live virtual or for watching a recording of the session. And that recording is available at the same link as the invite for today's Grand Rounds. We will be having some limited live viewership that will continue to shift as we go forward through the fall, occasionally available on Tuesdays at St. Vincent's. And for some of our endowed lectureships, we are hoping to be back live on Wednesdays at Providence Portland, so please stay tuned. I will be monitoring the Q&A throughout the session today. So please do go ahead and post any questions or any comments that you have for our speakers. And just as a reminder, next week we'll be hearing on the topic of environmental stewardship from Dr. Brian Chesebro, who's the medical director for environmental stewardship for Providence. And now I have the delight of introducing three speakers joining us today. First is Daniel Y. Segee. A registered nurse since 2012, he earned his nursing degree from Linfield. First started at Providence as a nursing supervisor in 2020, and then transitioned to Oregon Region Ambulatory Infection Prevention role in March of 2022. We're also joined by Dr. Justin Jin, an infectious disease physician at Providence Portland Medical Center. He attended Tulane Medical School and Tulane School of Public Health, and then did residency in internal medicine as well as fellowship in infectious disease at OHSU. And Dr. Jin serves as the medical director for infection prevention at Providence Portland Medical Center. And finally, we're joined by Dr. Wendy Drummond, an infectious disease specialist also at Providence Portland. She received her medical degree from the Kansas City University of Medicine and Biosciences. She completed her residency in a combined internal medicine and pediatrics program in Phoenix, Arizona, and then served as chief medical resident at Banner University of Arizona and the Phoenix VA Medical Center. Dr. Drummond completed infectious disease fellowship at OHSU and his affiliate faculty appointment there at OHSU and PSU School of Public Health, with particular expertise in a wide range of infectious disease topics, including non-tuberculous mycobacterial disease. And Dr. Drummond serves as the medical director for outpatient infection prevention for Providence, Oregon region. And now I will go ahead and turn it over to our speakers. Thank you so much.
Good morning, everyone, and thank you, Laura, for the really kind introduction. I'm going to move at a fairly good clip because I want to make sure that we have a good amount of time for question and answer at the end. But today we're talking about monkeypox, a very timely and hot topic issue. We're going to give a brief disease overview, updates on testing, as well as diagnosis and treatment. All right, so I'm just going to give you a quick background, and many of you may already be aware of this because there has been a lot of press about this particular infection, but this is an infection this is a disease caused by infection with the monkeypox virus, and it does belong to the orthopox virus genus. Since we've been talking so much about testing and disseminating a lot of information about this, you're probably already aware of this, and this particular genus includes the variola-virus, which is the cause of smallpox, vaccinia virus, which is used in the smallpox vaccine, as well as the cowpox virus. Now, the CDC has identified two different variants circulating in this current outbreak that share common ancestors with strains that have been present in Nigeria since 2017. Monkeypox as a virus was first discovered in 1958 following two outbreaks of pox-like illness in monkeys. And in terms of the reservoir, the specific reservoir is unclear, but it's thought to be small African mammals. And then it goes from, and they think that this is probably rodents that then pass it on to primates and then gets passed on to humans. So the first human case of monkeypox was detected in 1970 in the Democratic Republic of Congo. And there's two different clades. The West African clade is most likely what's circulating now, and this is associated with milder clinical disease. The other clade from the Congo Basin is more transmissible, and there is higher morbidity and mortality associated with this particular strain. So the first case of monkeypox in the United States during the current outbreak was confirmed in Massachusetts in May of 2022. You probably remember this. It got a lot of press. And to date, most of the reported cases in the US and globally have occurred in men who report sexual or close intimate contact with another man during 3 weeks before symptom onset. I'm just going to give you a brief epi overview just to sort of set the stage. And interestingly, we committed to doing this talk probably 3 or 4 weeks ago, and the epidemic curve actually looked pretty different back then because we were still on that upward slope. This is from Our World in Data, and I think a lot of people have used this throughout the COVID pandemic, but you can see the slope of this epi curve really looks like it peaked probably sometime in mid-August, and then you see that the cases are slowly coming down. The total number of global cases, and I checked the website this morning, is logging in at roughly 53,000. This is really an example of the epidemic curve for US monkeypox case trends, and you can see it follows a similar trend. This peak over here, I think that was the week of 8/22. This was a peak of 870 cases reported that week. And we're seeing, in terms of total US cases, we're now at almost 20,000, 19,962. The cases reporting, or the states reporting the greatest number of cases include California, New York, Texas, Illinois, and Florida. Now let's just briefly touch base about the situation in Oregon. And so these case numbers, these get reported every week on Wednesday. So you can always go to the Oregon Health Authority website. And so these, this most recent update is from August 31st. Total number of cases at that time reported in Oregon was 169, confirmed 100, and presumptive 69. And then I just wanted to show you a breakdown by counties, and I put the total number as well as the percentage. So you can see here at the lower end of the chart, Multnomah County has 119 cases sitting at 70%, followed by Lane County and then Washington County. Now, looking at cases by ethnicity first, you can see that the Hispano-Latinx community is here with 22%, non-Hispanic 75%, although we have seen that there's a disproportionate number of persons falling within that Latinx community. The epidemiology of this has been pretty similar across the board based on what we've seen worldwide, and then cases reported in the US and also in Oregon, where we're seeing the vast majority of cases in men, and this is sex assigned at birth, so 97%. You can see that there have been 4 female cases diagnosed in the state of Oregon, 33% living with HIV. And my comment on this is that certainly people with HIV, especially if they have uncontrolled or HIV, it'd be at higher risk for complications, but really we're just looking at a group, it's just a higher risk group in general based on behaviors. And then you can see the breakdown based on race. So this is a publication that was first published in the UK in the late spring. We first started seeing more cases emerging from European countries. So they were publishing some of the earliest epi work. And once again, as I mentioned, looking at the percentage of cases, 96% gay, bisexual, or men who have sex with men. Now, at that time, there really was this travel piece, and it's not to say that you shouldn't ask about travel, because you should, but once it gains a foothold in the country, this is probably of lesser importance at this point. But thinking about travel abroad prior to symptom onset, within 21 days of that symptom onset, age under 30 years, 21%, and you can see some of the breakdown here on HIV treatment. Among those living with HIV, you can see that 95% or 99% of those cases were on HIV treatment, roughly 30% living with HIV, and that's really the percentage that we're still seeing across the board. One thing I wanted to comment on, because I thought this was really interesting, is there was a survey done looking at changes in behavior since this was identified as an outbreak in the United States. And this was published in the MMWR, Strategies Adopted by Gay, Bisexual, and Other Men Who Have Sex with Men to Prevent Monkeypox Virus Transmission. You can see August of 2022. So this was a recent survey of gay, bisexual, and other men who have sex with men. And you can see that this was done in the first 2 weeks of August, and it was a monkeypox specific survey completed by 824 men who have sex with men. And approximately 50% of those individuals reported reducing the number of sex partners, one-time sexual encounters, and use of dating apps due to the current monkeypox outbreak. And I can say anecdotally, I've had a lot of my HIV and PrEP patients report that they've made some significant adjustments in their behaviors as well. At the time that this survey was done, 1 of 5 reported receiving 1 or greater doses of vaccine to prevent monkeypox. There's been a lot of education and a lot of outreach going out to these groups in order to try and slow down transmission. And I already mentioned that we've seen a disproportionate number of cases among Hispanic or Latino men. I'm actually not going to spend a lot of time in this, but if you go back and look at the slides later, you can see that there's a breakdown based on different high-risk behaviors. I want to shift over and discuss the clinical syndrome. So what I'm going to talk about first is really sort of the textbook or historical clinical syndrome of this disease process, and then we'll talk about specifically what we're seeing in the most current 2022 outbreak. Incubation period, typically 5 to 13 days, range of 4 to 17, and the illness usually lasts around 2 to 4 weeks. And I would say that, you know, this top information is really similar to the current outbreak as well. Now, generally speaking, there's usually a viral prodrome. So what I mean by that is symptoms that patients experience prior to the onset of the rash. So this can include fever, malaise, headache, and lymphadenopathy. And this can be generalized or localized. And the presence of the lymphadenopathy is actually a distinguishing feature from chickenpox or varicella. So something to consider when you're thinking about differential. Now, the rash and the more conventional presentation usually presents after the prodrome, and there is a typical progression. So usually the lesions develop and evolve all at the same time, all over the body, and it can involve any part of the body, and it can involve the palms and soles. And one thing that I want to point out, sort of a little clinical pearl, when we think about rashes, is that another disease process that can cause a rash that involves the palm and the soles is syphilis. And certainly syphilis is part of the differential. And we are seeing a lot of patients who are diagnosed with multiple STIs at the same time that they're diagnosed with monkeypox. So something to keep in mind. These lesions can be well circumscribed, and they're characterized as deep-seated. They're firm, they're rubbery, and they can be painful, and they can cause significant itching. Now, there's typically 4 stages, and this is actually true with the current outbreak as well. They first start out as macular lesions. Oh, and then not popular, vesicular, pustular, and then into that scabbing and subsequent healing stage. And here are some examples of some of the more classic monkeypox lesions. You can go to the CDC website where they have a nice archive of all kinds of different pictures. So this is an example of these. It's moved into the pustular phase, and you can see that they have this, what we call this umbilicated appearance, where you see this indentation. Another rash in which we see a somewhat similar appearance, although there are some differences, is that of molluscum contagiosum. Here's another lesion that you can see. This is more of that vesicular moving into the pustular phase. This is an example of a pustular lesion. And then you can see how these have become more advanced on this person's, the distal part of the upper extremity. So just briefly touching on what's going on with our current outbreak and what does the clinical presentation look like now. So these are really the key differences that I want you to keep in mind, is that the prodromal symptoms are often absent in these patients. And a lot of these patients who are reporting symptoms follow the onset of rash. So in that sense, they're not really prodromal, right? I mean, this is actually occurring after rash onset. Instead of being more diffuse, although we are seeing some patients who have a fairly diffuse rash, generally speaking, these are confined to a local body site. We're seeing these in the genital or perianal region. Patients are presenting with oral or pharyngeal or lesions involving the pharyngeal mucosa. In contrast to the more typical presentation, they may not develop all at the same time in all body areas. And in fact, patients are reporting some patients will have oral mucosal lesions first, and then perianal, and then genital. So it's really all over the map. One thing I do want to highlight is it is often starting in those mucosal areas. Patients are also reporting significant symptoms of proctitis. They're reporting significant anal rectal pain. Some patients have noted rectal bleeding. This may be associated more commonly with the ulcerative skin lesions as they progress over time. Some patients have had very severe pharyngitis and had secondary peritonsillar abscesses, so we can see secondary bacterial infections in these patients. So keeping that in mind, especially they can develop secondary cellulitis involving the skin lesions. And some patients have been hospitalized mainly for pain management due to this significant mucosal involvement. So that really speaks to the management of these patients. Now, you can always take a look at these slide sets later, but I also put the source down here. So at the very end of July, first week of August, there was this great publication, Thornhill 2022, New England Journal of Medicine. And these are just different examples of the lesions. And I encourage you to go to this publication, but specifically take a look at the appendix, because there are so many pictures of different lesions, the evolution of the lesions. I think it's really interesting how it correlates to PCR positivity and negativity, which I'm not going to spend a lot of time on, but I just want you to know that there's pictures within the article itself, embedded in the article, but there's a supplementary appendix that I really encourage you to take a look at. But I think it's nice that you can see the evolution of lesions over time, and these are just different perianal lesions. This is an example of evolution on the skin. So keeping in mind that it starts as the macular, vesicular, pustular, and then some example of oral lesions. And here's some lesions on the sole of the foot. And then just once again, just appearance of different types of lesions. So I really encourage you to take a look and familiarize yourselves with this. And you can see this characteristic umbilication, and just as they progress through the different stages. I already mentioned some of the complications, including secondary skin and soft tissue infections, peritonsillar abscesses. They can also develop pneumonitis. There have been some case reports of encephalitis, site-threatening keratitis. Mortality rates vary, although generally speaking, with this current outbreak and given the specific strain that's circulating, it is less invasive, and we've seen one case of mortality in this country, although they don't necessarily think it was related to monkeypox specifically. It was someone who had a diagnosis of monkeypox, who was severely immunocompromised, but they haven't reported all the details of that case yet. And speaking to that on this slide, so reported death in Texas. And then there were 2 cases of encephalitis in Spain. This was in individuals age 44 and 51 who were non-immunocompromised. So risk factors for more severe disease, and I suspect that Dr. Jen will speak to this in a couple of minutes, but anyone who's immunocompromised or has underlying or mild to severe immunocompromising conditions. The other thing I wanted to point out here is history of eczema, atopic dermatitis, or other acute exfoliative skin conditions, patients with psoriasis, young children under 8, and lesions in the face and eye. So thinking about, okay, who are the individuals do I need to get involved with this patient's care? Thinking about ophthalmology, for example. And this is just that brief research summary of that Thornhill article that you can refer to later. And this just, once again, this is looking at 528 cases in the United States, and this breaks down the different clinical characteristics. And I've really sort of highlighted this before. This is just to say this is very similar to what we were seeing in that UK study, but knowing that as more cases get diagnosed over time, this epidemiology is going to shift. So we already know that we're seeing increasing cases in females. Now, these tend to be people in higher risk sexual groups, including persons who are bisexual, so women who are having sex with men who have sex with men. We have seen pediatric cases, but those have been close contacts to other known cases. And then I just briefly wanted to include a slide about persons with HIV infection. Once again, we've seen patients who have been diagnosed who have multiple STIs, people who've been diagnosed with acute HIV, but a lot of these persons are individuals who are already living with HIV. I'm just pointing out that the vast majority of these patients are well controlled. Their mean CD4 count is 680. Generally speaking, these patients have a undetectable or well controlled viral load and are presumably immunocompetent. Now, in terms of transmission, I've referenced this already, but generally occurs through contact with bodily fluids, wounds on the skin or internal mucosal surfaces, respiratory droplets, or contaminated objects. And here's the nitty-gritty, right? Direct contact with infectious rash, scabs, or body fluids, respiratory secretions. So this isn't COVID, folks. This isn't, there is potentially aerosolization. However, it's really respiratory secretions during prolonged face-to-face contact, intimate physical contact, such as kissing, cuddling, or sex, touching items previously touched, the infectious rash or body fluids, and then placenta, so vertical transmission in pregnant women. And then potentially inadequately cooked meat or products from infected animals, but this is really what we're seeing in persons who've traveled or in Africa. We've already talked about most of this. I would say that one thing I want to emphasize is that patients are infectious once symptoms begin, so prodromal or rash, but keeping in mind with this current outbreak, primarily seeing the rash first, and these individuals do remain infectious until lesions form scabs. Scabs fall off, and there's a fresh layer of skin that's formed. I think I'm going to move on from this, but this is just looking at a study that was published back in 2019, just looking at the human-to-human transmission that's been well described. Secondary attack rate can be as high as 8%, but it really depends on the specific strain. So diagnosis and differentials. So if you have a person who's calling or presenting to clinic, I've had some of my PrEP patients sort of sneak in for a PrEP visit, but really the reason that they're there is because they have new lesions that they're concerned about. Please, 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 please ask lots of questions and complete a sexual and travel history for the last 21 days. The other thing that's really important is to conduct a very thorough skin and mucosal examination, and you need to look in really all orifices, please, genital, anal, oral, and you need very good lighting. There may be lesions that they've been very dismissive of, or maybe it's something and you want to make sure that you get a good look at it. And then there's just a really broad differential for the rash, and especially in this patient population, as I've referenced before, thinking about other concomitant sexually transmitted infections, including syphilis, any of these STIs that can also present with skin lesions. Now, varicella zoster is not conventionally considered an STI, of course, but just thinking about the rash presentation, herpes simplex, molluscum contagiosum, LGV, which is caused by chlamydia. And what we do encourage you to do is screen for these other STIs. You're probably going to want to empirically treat for a lot of these things, even pending results, depending on your clinical suspicion for other STIs. And also, there have been some persons who have also been diagnosed with acute HIV, and that can present with a macular rash, but just keeping that in mind. Testing for suspected monkeypox. Well, who to test? It's not everyone with a rash. So once again, this is why we want you to really familiarize yourself with what this rash looks like in the different stages. really thinking through what an individual patient's risk factors are that we've already reviewed. We want a reasonable threshold for testing, okay? Recommended specimen is a skin lesion material. A swab from any part of the body is acceptable. You do not need to unroof the lesion. We do recommend that you swab vigorously to collect an adequate sample, as this helps you collect enough DNA to be detected. There we go. Thank you so much for your attention, and I'm going to hand this over to Daniel.
Good morning. Just as a reminder, I'm Daniel Wise-Sagi. I'm the ambulatory or outpatient infection preventionist for the Oregon region. So we're going to go over a little bit more about what do you do when it lands in your clinic, because I have generally been the touch point for most locations when this has come up. So I have helped a number of folks kind of guide them through the process of what to do, what do we wear, and what happens next. Those tend to be the questions I field most commonly. Well, let's get into that part. First and foremost, PPE tends to be the question that we tend to lead off with. So standard stuff we already have is completely adequate. So we have gloves, we have gown, we have eye protection, and an N95 mask, cap or PAPR or equivalent. The other question that usually follows that immediately is, what do I do now afterwards? They've had a gown, they've been in a room, like what do I need to do? The upside here is that monkeypox as a virus is actually weaker or more fragile compared to coronavirus. So it's actually easier to clean and get rid of. All the products that we have that work for COVID will also work for monkeypox virus as well. As Dr. Drummond spoke to before, the fomites of concern really are items that touch a person's body either fully or partially. The things most concerning are going to be linens, towels, patient gowns if they spend time in them, things that are soiled and potentially come into contact with the discharge from those specific lesions. But again, the main items of concern here are the porous surfaces. So less concerned about incidental contact from clipboards, pens, things of that nature. They're not absorptive surfaces really, compared to what we would be more concerned about, the things that really do touch a whole person's body and also have the properties where they could absorb some of those bodily fluids and then kind of hang on to them for a while. Main thing to note here, at least as far as laundry is concerned, is that there is a concern that if someone has shed either scabs or other pieces of their skin into a patient gown, that should be gently put into a laundry bag as opposed to, no big fluffing out. That would be undesirable. You want to make sure that you sequester this laundry in a gentle manner into a bag, and then it can go through your regular laundry process for soiled linens. Again, a lot of the impetus here is to avoid potential aerosolization of skin particles or scab particles, especially if they've been in for a vigorous swabbing, as is required during the specimen gathering. You do want to try to limit any process that might kind of bring that dust up as much as possible. Dr. Drummond thankfully also covered this a bit, but I'm going to hammer it home because these are the notes that I read. Got to make sure that you ask the questions about exposures to known cases, especially. That is your number one risk factor right off the bat. Have they come into contact with someone who they know who has the lesions, or in the events that we're dealing with more frequently, do they know someone that they have had a sexual encounter with has had a sexual encounter with someone who might have lesions? Because a lot of times these networks are very close-knit, but they do involve more people than you would initially expect. The other piece of it, as we went over before, is making sure that you do fully examine the body for lesions, especially oral, rectal, intraanal lesions. They're not obvious in the first place. Some folks can have those lesions and not be aware of them in the first place. And in particular, too, here, really going into the sexual history, especially. So if the patient is someone who engages in unprotected sex, how often, when was the last time, who are they having sexual encounters with, and are they able to contact any of these partners to ask or inform about these potential STIs that they are then going to be diagnosed with? And at least a couple different encounters that I have been a part of, patients were able to immediately text or reach out to previous partners that they had and find in that moment that person was being treated for monkeypox right then and there. So it was an easy loop to close at the moment, but you have to ask the questions to find out. And in particular, too, detailing the type of exposures that they are having is really helpful to determine where the risk factors are going to lie and if there are more potential people in this loop that need to be made aware of this potential exposure. Getting the samples. So first and foremost, no cotton swabs. They are not accepted whatsoever. And as Dr. Drummond pointed out, unroofing lesions is unnecessary. And in some cases, this can be extremely, extremely painful. So that is not going to win you favors, at least when you're trying to get your sample either way. First and foremost, too, we have had a number of situations where there have been a variety of questionable appearing lesions, and rightly so. Providers want to swab a couple of them because they're concerned they might be other co-occurring STIs. And in that case, you do need to be very diligent about labeling all of these different samples as you are gathering them, both so that you can keep track of which thing you were concerned about at the time, but also these, if they are sent to the lab not specifically labeled and or categorized, you're going to trigger a lab exception that's going to delay processing, and it's going to delay the lab processing time from LabCorp, who processes the majority of our monkeypox samples currently. It's only going to push that turnaround time out even further, which is not fun for anyone involved at all. Big clear note, LabCorp thus far will always accept a swab sent in a dry, sterile urine specimen container. Everybody should have those at any location of any kind. Those are just standardly ubiquitous. UTM and VTM transport tubes, so the things we most commonly would use for cultures or other samples, those are also acceptable. However, I will note that specifically there is a single brand that LabCorp has an issue with, where they have some sort of reference results mismatch for their equipment, where they will not accept the Merit Medical Cultura tubes, but otherwise they will accept any of the other tubes currently in use. And as always, you can always fall back to the sterile urine specimen container. That one will work regardless. Patient disposition. So one of the big things we're seeing here especially is that because these results are being run out of a commercial lab that we're connected to, those positives are being sent to the state before we even know that their results are done processing. So you do need to prepare your patient that if they have a positive result, they're likely going to be contacted very quickly by the local county health department the moment that those results are pushed to them from the commercial laboratory service. So I've definitely seen a number of encounters where patients have contacted us to let us know that they were positive, and we hadn't even seen the result back yet, because that's just how Johnny on the spot LabCorp is with doing their mandatory reporting. So it's important to let folks know that, also because you do want to make sure that you have contact methods for your patient hammered out prior to when you need to reach out to them to let them know. Especially in the case of the health department, they're going to want to be able to do contact tracing and discussions with patients, and they need to be able to do that in a timely manner just to save everybody more headaches. Right now, the quoted time, at least from LabCorp, is around 3 to 5 days for processing, although that's really pushed out to potentially 7 to 10. In practice, from what I've seen, having tracked the majority of the results that actually come through, it's more along the lines of between 4 and 6 days. Keeping in mind, too, that if someone is being screened for monkeypox, this should mean that they're isolating at home in order to prevent potential exposure to others. So do need to account for that in your work notes or other excuses that you would be signing off for folks. And also that ends the moment they get the result back and it's potentially negative. So upside for that. The other thing, too, to let folks know is that if their lesions get worse after they see you, there are options. So some folks have come in with just a couple lesions, not really that burdensome at the time, but it has escalated quickly thereafter. And a lot of folks kind of tend to, well, what do I do about it? While the mortality for this is extremely low, it's not comfortable. So it's not necessarily a condition that you would be happy to leave people to enjoy on their own at home, especially when we have options to deal with it, or options where if it really is particularly painful and or is threatening sense of sight, nose, mouth, airway, there are options. We have treatment. Dr. Jim will be speaking more about that right after this. Don't forget, if you're not sure, you can ask. That's what we're here for. I always am happy to field questions when it comes to monkeypox at this point. It's been my #1 topic of conversation for the past month. So that's what I'm here for, as are we all. So I'll hang it over to Dr. Jim.
All right, thanks for the invitation to speak. I'm going to talk a little bit about monkeypox vaccines and kind of history behind the development of these vaccines. Also talk a little bit about treatment as well. as any of these, 3 sections that Dr. Drummond and Daniel spoke about, I think could be whole like 45-minute hour talks by themselves. So I'm going to try to go through a lot of information relatively quickly so we have a little bit of time left over for questions. So, smallpox vaccinations have been around for centuries. Smallpox, in the past 20th century is estimated to have killed about 300 to 500 million individuals. Used to kill, before effective vaccines were available, about 5 million people estimated per year. So this process of varialization, or exposing non-immune individuals to smallpox by either scratching scabs into their arms, or using crushed up scabs from smallpox and blowing it into their nose, as this top picture shows, has been described in for well over 1,000 years. It was risky, a case fatality rate of about 0.5 to 2%. But, smallpox by itself had a case fatality rate of estimated about 30% or so. So in about 1796, we probably all learned about this in immunology, but Edward Jenner had noted that milkmaids who had contracted cowpox had been protected from developing smallpox. So he took a scab from a infected milkmaid that was infected with cowpox and inoculated it into a 9-year-old child, the son of Jenner's gardener, this guy James Phipps, and he exposed this patient to variola several times, and he never became ill. And so this whole process of vaccination got started after this process. It probably would never get through the IRB currently, though, but was an important step in eradicating smallpox. So currently, we don't use cowpox vaccinations for cowpox virus for the vaccinations. We use vaccinia virus. They're all members of the orthopox virus family. They are very highly conserved across the orthopox viruses, so the proteins from one orthopox virus tends to provide immunity to the other orthopox viruses. So vaccinia virus will prevent smallpox, and that's currently the strategy that we're using right now with our monkeypox vaccination campaign. Smallpox was eradicated in the early 1970s, but there was also concern that the Soviet Union had been producing large amounts of smallpox for biologic weapons program, and there was always a concern for possible terrorist threat, especially after the fall of the Soviet Union. So in 2004, there was the project Bioshield that was started by the U.S. government. The older vaccination DryVax was being removed from the strategic national stockpile, and the U.S. government had come up with this agency to try to come up with strategies to defend against certain types of terroristic attacks, like biologic, chemical, radiologic attacks. So the BARDA, Biomedical Advanced Research and Development Authority, was established under the DHHS to manage Project Bioshield, and they were tasked with being the liaison between biomed industry and the government to develop drugs and vaccinations. So the first vaccine against smallpox to be developed under this was the ACAM 2000. This is made from a replication competent vaccinia virus, and it was licensed in 2007 and officially replaced DryVax in 2008. It uses a cell culture technique instead of the old DryVax vaccination technique of growing it on the skin of calves and collecting lymphatic fluid from the calves. It's a single dose given with a 2-pronged needle, kind of like the old DryVax vaccination. And the U.S. government has about 200 million of these doses in stockpile. It's been used selectively in military populations pre-deployment. I believe that if you go to Korea or to the Middle East, they've been vaccinating soldiers going into that area for many years. The problem with the ACAM 2000 is there's quite a few side effects. You get a sore arm, fever, a lot of the kind of similar constitutional symptoms that you get with any vaccinations. But the major issue that we're worried about is the myocarditis. And about 1 in 175 adults that receive this vaccination will get some type of cardiac complication. eczema vaccinatum in individuals with dermatitis or eczema can be a complication. You cannot give this vaccine to patients with immunocompromised due to the risk of progressive vaccinia. There's been neurologic side effects, including encephalitis and meningitis, and just overall risk of developing or spreading it to other people in the environment. Because if you look at this, the day 4, 7, 14, 21, virus is being shed from this since it's a replication competent virus. So you could potentially infect somebody that was immunocompromised. So the Jynneos vaccine, also known as Imavune, and I think that's in Europe, and Imvanex, I think that's in Great Britain, is made from the modified Vaccinia ankara virus, which is a non-replicating Vaccinia virus that it was developed by this company Bavarian Nordic, and it's produced, I believe, in Denmark. It was developed essentially as an alternative to these older ACAM 2000 vaccinations to provide vaccines for immunocompromised individuals in case if there was a bioterrorist attack. You can use this in patients with eczema and patients with severe immunocompromised. It's a 2-dose series. First dose is the traditional dosing, and I'll talk a little bit more about the intradermal dosing, is a sub-Q dosing. For post-exposure prophylaxis, it's ideal to give it within 14 days. Within 4 days, it will help prevent infection. 4 to 14 days will help reduce symptoms. And the safety profile is much better than the ACAM 2000. There's no risk for transmission to immunocompromised because you don't really have that open take that you have with the traditional vaccines like Dryvax and ACAM 2000. And the cardiac side effects are thought to be much lower as well, although we are they're actively monitoring for evidence of myocarditis and other complications. So talk a little bit about intradermal dosing. So it's been estimated that there's about 1.7 million or so individuals in the US that are at risk at high risk for contracting monkeypox, and we require about 3.2 to 3.4 million doses of Jynneos to be able to adequately vaccinate this population. However, due to production issues and supply chain issues worldwide, only about 1.6 to 1.8 million doses would be available by December 2022. So the CDC and the FDA met, and they put together they approved an EUA in early August to do intradermal dosing at 1/5 the dose, so 0.1 mLs. Versus a 0.5 ml dose for the sub-Q dosing intradermally. The bottles come in a 0.5 dose, so ideally you can try to get 5 doses out of there. I think in practice it's more like 4 or so, kind of depending. These regimens are interchangeable, and we have been extending out dosing as well. I know, like in Europe, like I think in Britain, they've been trying to get as many first doses in the arms as possible. In the US, we've been doing the same thing as well. But right now that supply chain issues are getting a little bit better, especially since we're doing the intradermal dosing, we are recommending trying to get the second doses in individuals' arms. As far as efficacy goes, so, we don't really have clinical efficacy for any of these vaccines right now, but what we do have is some titer data, this comparing sub-Q and intradermal dosing. And what you can see, this slide really kind of shows you, is that it looks pretty much the same. So this, this modified Vaccinia ankara has been given intradermally in Germany since the 1970s, and they've shown some really good success. At least as far as titers go, no real difference in titers seen between the two different dosing strategies. How to administer intradermally? It's for any of us that have placed PPD test, it's essentially the same technique. So it's you make that little wheel. monitor patients for about 15 minutes. If they've got a history of anaphylaxis to Gent, Cipro, chicken or egg proteins, then we observe them for 30 minutes. One of the major contraindications for giving it intradermally would be if they've got a history of keloid scars. As far as reactogenicity, the major difference is people that get intradermal injections have more erythema at the site, induration at the site, and itchiness at the site. It seems like you get more pain subcutaneously. So I've seen some patients that have had rather large indurations that looks like a positive PPD on their arm. So there's been some alternative intradermal site recommendations given by the county, especially if they're coming in for that second dose at a month and they still have a rather large sub-Q or a rather large induration at that site. You could either go to the other arm, or there's subscapular on the back. Just below the scapula or the upper thigh. They also mentioned that as a potential alternative site for these injections. As far as the guidance goes, who gets this, the standard, standard post-exposure prophylaxis, so contacts of people with presumptive or confirmed monkeypox, contacts of people with presumptive or confirmed monkeypox in another jurisdiction. Vaccination can also be considered for contacts of people with suspected monkeypox if the index of suspicion is high enough. And timely vaccination contacts might not be otherwise possible. There's also the pre-exposure prophylaxis, which is a little bit different than the current OHA guidelines are a little bit different. They break it up into PEP++, but this is essentially the same. Cisgender men, transgender women, and non-binary people who have sex with men and who meet one or more of the following criteria. So have had more than one sexual partner in an area, experienced a community transmission in the past 2 weeks, or have been diagnosed with a sexually transmitted disease or infection in the past 3 months, or taking HIV pre-exposure prophylaxis, or living with HIV and meet criteria A or B. Also people of any gender or sexual orientation who are engaged in commercial sex work. So how effective is the vaccine in preventing infection? This is a preprint article that was published pre-published out of France, where they looked at 276 individuals who received the Imvanex vaccination, which is the European equivalent of the Jynneos, after high-risk contact with PCR-confirmed monkeypox patients. So the median delay in this study for the breakthrough cases, and there was 12 out of these 276, was 11 days. So, not within that 4 days after exposure to prevent disease. The average, or I think most of these individuals had breakthrough cases within 5 days, although you did see these two cases, patient 11 and 25, who had breakthroughs at 22 and 25 days, which was a little weird. 4 out of the 12 of these patients were HIV positive. Interestingly, 29 of the patients of the 276 had previous smallpox vaccinations from previous vaccination campaigns, probably, they were probably much older, but only 2 of those had breakthrough infections. There was an older study from the early 80s looking at smallpox vaccinations to prevent prevention of monkeypox outbreaks in the Congo, or actually Zaire back then. And they showed about 85% efficacy for smallpox vaccinated individuals to preventing symptomatic monkeypox cases. It's unknown, though, how long that duration lasts. I think some people believe it probably lasts a lifetime, but there's really not great data on that. Jynneos doses administered, there's been over 352,000 cases, doses that have been administered in the US so far. I'm going to go through these slides relatively quickly. In Oregon, we've received over 9,000 doses. Over 6,700 doses have been administered as of last week, and currently available doses are about 25,000, 26,000 doses. And if we use our doses, we could potentially get more allocated by the CDC. Currently, the Providence has opened up a Jynneos vaccine clinic. It was last week. So they're available through the virtual sick clinic, and they're helping schedule. So Tuesdays and Thursday evenings, Tuesday evenings at Gateway, Thursday evenings at Sunset. And this is the number for VSC. If you are an employee that has a high risk exposure, so if you're not wearing proper PPE and come in contact with a known monkeypox case, then you would contact Caregiver Health Services to get post-exposure prophylaxis. This is a good website. This is a good resource for the Jynneos vaccination. It goes through, it goes through all the different administration techniques and what to do if you have an error on administration. So I'll leave this up here, or it'll be in the slide set that you guys can take a look at later. Therapeutics, most people will recover, as been discussed by our previous speakers, but the main thing is pain control. If they have perianal lesions, stool softener, sitz baths, topical lidocaine can sometimes help as well. But tecovirimat or TPOX was one of the drugs that was developed under Project Bioshield, FDA approved for treatment of smallpox in adults and children under the animal efficacy rule. So animal efficacy rule, there was obviously no human challenge trials, but it has been approved for use in orthopox virus or smallpox. So there's oral that was approved in 2008, and the IV was approved more recently. It's available by EAIND from the Strategic National Stockpile. Weight-based dosing. Oral needs to be taken with a fatty meal. So it's twice a day, weight-based. So you would have to give it with, I think it's like 25 grams of fat per meal. So if they're unable to take oral, if they got a history of problems with potential absorption, like gastric bypass surgery or something like that, then you might need to move towards the IV. We avoid IV formulation in individuals with creatinine clearance less than 30. Real quickly on this, it essentially targets a VP37 protein, which is only found in the orthopox virus family, and it prevents maturation of mature viruses. Indications, we talked a little bit about this. So severe disease, confluent lesions, encephalitis, hemorrhagic disease, or other conditions requiring hospitalization, high-risk patients, immunocompromised, peds, pregnant people, history of atopic dermatitis, if they're unable to take PO, secondary skin infections, and then ocular infections are going to be high risk as well, and then other areas where that might be relatively sensitive. So GU areas, perianal areas, if they're unable to defecate, then sometimes we're having a ton of pain. Then oftentimes they're going to have to get admitted to get therapy. TPOX, we do have it available through the expanded access IND process. Virtual sick clinic is also managing this. And then there's paperwork that needs to get filled out. ID is always available to discuss high-risk patients, and the virtual sick will help with these intake forms. Efficacy, this was just published fairly recently. It was a case series out of UC Davis. And it looked like people had very good response to therapy, very well tolerated, and did help with symptom decrease. Post-exposure prophylaxis, there's a couple trials going on right now, so I'm just going to go through going to skip this slide. Other therapies, there's a bunch of other therapies out there, but TPOX seems like the most promising. So if you have questions on that, you can ask about those later. So I'm going to stop there so we can take a little bit of time for questions.
Great, many thanks to all three of our providers. So much information provided. I think you answered many of our questions as we went along. I just want to point out, thank you to our librarian who has also provided a link to the Thornhill article there in the Q&A section, so feel free to refer to that. Perhaps a couple logistical questions. It's really wonderful to see the availability of the virtual sick clinic being able to help with vaccination and also with treatment. Can you talk a little bit about logistics and timing of referring to them if you're seeing a patient in whom you have a medium level of suspicion as to whether this is actually a monkeypox diagnosis or not?
Are you referring to therapeutics or for vaccination?
I think a patient presenting with a potential monkeypox infection, should they be referred for further evaluation with the virtual sick clinic straight away, or try to handle within your own clinic?
Well, I think most clinics should be able to do the testing. And so, virtual sick is available if the patient is sick enough and meets criteria for evaluation for TPOXX. So, if they're having just if there's a few lesions, then, probably our recommendation at that time would be to, have them swab, tell them to, monitor at home, isolate at home. But if symptoms worsen, then if you're getting that call, like I can't eat, or I'm having, severe pain, or things are worsening clinically, then that might be the discussion where you would refer them to the virtual sick so they can start the TPOXX process.
Perfect, thank you. That makes good sense. And I think Daniel might be weighing in as well, and perhaps we'll add one clarification to that. Did we understand correctly that any patient with a diagnosis should then go on to receive the vaccine at that point?
Generally, no. Once you're symptomatic, we would not recommend vaccination at that point.
Yeah, that's part of the point I was going to clarify a little bit. If folks have had an exposure, but they have not yet had an eruption of lesions, that's kind of the golden window where if you can get them scheduled through the VSC to get vaccinated, that will either potentially remove the eruption of lesions as the course of their illness or dramatically shorten the duration that their lesions are present. So if you can get them in that window of time, that's the best time to do it. If lesions have already erupted, that window unfortunately has closed for them and vaccination will not be as helpful. Then it's a question at that point of supportive care, unless TPOXX becomes then a potential option, and if their symptoms have advanced to that degree that might be something that is needed.
It's thought that they're going to develop good immunity with disease. So, unlike other processes where we might say, yeah, go ahead and vaccinate them as soon as you can, these individuals will have pretty good immunity following infection.
Perfect, thank you. And thank you for the materials that have been put together. I imagine those include information for patients who present and then wonder what to tell other people, including household contacts of their own with regard to next steps. Any comments that you've had on that of where we should go for those details, or any particularly important points to let patients know regarding their contact with others?
So I could say that we've mostly been utilizing the resources that the Oregon Health Authority have put together for folks that have kind of detailed summaries about what does it mean if your doctor tells you that you're being tested for monkeypox. What does this mean for you? What should you be doing? It kind of outlines both the isolation piece of it. It also goes over a little bit of like, what are your risks of transmission? Like, what do you need to limit for yourself for potential cohabitants or friends and family that live with you at that same time? Those tend to be the resources we utilize because they're pretty well thought out, and they update them on a regular basis. They also are offering them in more than 14 different languages as well. So if language barrier is a concern, OHA, they got you covered for most of it. So.
Perfect, thank you. Again, such a comprehensive presentation. We really appreciate not only the presentation, but all the work that you've been doing on behalf of all of us with this outbreak ongoing. We are just coming up to the top of the hour with 1 minute. I'll leave an opportunity in case there's any last thought from any of our presenters. Thank you to our audience, and we'll see you next week.
I just wanted to quickly say that there's been a document, the Monkeypox Playbook, that's been widely distributed. Daniel spent a lot of time on this. There's been a lot of input, and it has links to that documentation, patient education, how to submit to the lab. So there's a lot of helpful information in that document that's gone out through practice alerts.
Thank you very much. Yes, we have seen that document. And when we send our follow-up email regarding this presentation, would be a great opportunity to include that again. So thank you.
Now includes an algorithm to help you figure out what you should do next.
Perfect. Thank you all. Take care.